Hello and welcome to Real Menopause Talk. My guest today is Dr. Heather Hirsch. How could we all have not known? Her recent appearance on Oprah Daily with Oprah Winfrey, Drew Barrymore, Maria Shriver and Dr. Sharon Malone opened up many questions for women worldwide. So we talk about how could we all have not known about perimenopause and menopause. I ask her opinion on HRT and when best to start it, should you choose. And she very interestingly puts the onus on the medical community to educate themselves and then the rest of us. We also discuss her new book, Unlock Your Menopause Type, in which she demonstrates personalizing your treatment plan. She goes through many of the symptoms individually, offering a variety of solutions, and she really nails long-term self-care. And keep listening for the number one essential ingredient for great health. Dr. Heather Hirsch, lovely to meet you. I'm very excited about our conversation about everything that you do, including your new book, which we will get to very shortly. But first of all, would you like to start off by telling everybody a little bit about you so they get to know you?
Yes, absolutely. So thank you for that lovely welcome to your show. I'm a menopause doctor. And when I went to medical school, I never thought my dream was to be a menopause doctor. But I always loved taking care of women. And I started in OBGYN, delivering babies and doing surgery. But I found that I really enjoyed the most helping women make complex decisions. And therein lies sort of what I do with most of my time now. So I did some fellowship training at Cleveland Clinic, and that's where I had my aha moment. I was so surprised. People were flying from all over the country and the globe to go to Cleveland for help for this mysterious thing that was happening to them around midlife and menopause. Or they had lots of questions about the safety of HRT and why they couldn't get it from their doctors. And I realized that we have, solved birth control. We know a lot about preventing pregnancy, how to get pregnant when you have infertility, and a lot about pregnancy, and now even more about postpartum conditions. But after that, there was really just this black hole in terms of women's health. So I wanted to jump into the black hole because I really felt as though women were being mistreated and not seen and not heard in midlife care. So I am now a menopause doctor.
And you're doing not just what somebody might expect from a menopause doctor, you're doing so much more. You've set up your own, not just your own clinic, but your own school. Is that right?
I have. So along my journey, especially during the pandemic, during lockdown, I wanted to, one, do some stuff with all my free time. But I always felt this burden on my shoulder that the math didn't math of how many women needed care in midlife and menopause. In the United States, there's 30 to 50 million women in the perimenopause to menopause transition. And then about 1.2 billion women worldwide are expected to go through menopause in the next 3 years. So just think about those numbers at scale, right? It's a universal truth for women if we live that long enough. And I thought, how can I help more women? I can only see X number of people a day, and it's not a lot. It's like 10 or 12 or 13, or on a really good day, 15, but that still, there's just not enough. So then I started putting together courses for women, and I really, really loved that. And then more recently, I had a lot of clinicians asking me for a clinician class. So I put together a clinician class, and now I've trained, several doctors who are so interested in midlife and women's care, and particularly HRT, because and importantly, not because that's the only one right answer, but because we didn't learn a lot about this in medical school and medical training. And so I started my course. I started a YouTube channel. I wrote a book during, most of the pandemic because I really wanted to reach those women for whom I couldn't see just in my clinic.
Which is, like you say, so many millions. And I love the fact that you've just taken the bull by the horns and are reaching as many as you can. And what better way than writing a book as well, which we will come to in a moment. It surprises me still that I've interviewed more than 100 people for this podcast, and nearly all of us, I would say probably 90% of us, have arrived at this period of our lives absolutely clueless. And whatever symptoms we have, we don't know why they're happening. We don't know what's happening to us. And it appears that it's very much the same in the States. You've mentioned already the education that you get in the States, or the fact that you don't get so much when you're training to be doctors. At the moment, there is legislation going through in the UK to say that it will be part of the curriculum for our GPs. But so far, I think the maximum that they have to learn takes 4 hours. Where is the States in terms of educating the doctors?
What a great question, because that is one of the biggest barriers. And by the way, I have patients certainly from all walks of life, and they say the same thing. They'll say, "Oh, I'm so educated. I'm so smart. I'm so well read. Like, how could I have not known?" And it's so unempowering. But I always say that I still think the onus is on the medical community. It's on the medical community. However, the galvanizing has been from women who listen to your show and others who are starting to pull ahead of the medical community. Now, the UK is a few steps ahead of the United States, and we don't have the same type of political movement in terms of mandating education for clinicians, particularly around midlife and menopause. Now, I always tell my students, whether they're practitioners or laywomen or my patients, at some point, I'm really excited to move into the advocating arm. And as I have really gotten to dive into the social media and content world and content creation and created a little bit of a following, and then connections with other clinicians who have more following, I really think that we are on the brink of a revolution here. But where are we? We're still a few steps behind.
We're still very much a few steps further back than we need to be, but you're very right. I think our generation is the one that is going to radically transform the whole menopause landscape.
Mm-hmm.
Whereabouts are you in terms of perimenopause?
So I will tell you, I am 40, almost 41. I'm probably in perimenopause because it's funny. I was walking around very irritable and have been kind of irritable on a cyclic sort of schedule. And I was talking to one of my other colleagues who's also a clinician, and I was like, I should know, right? So just so you know, if y'all are confused and I'm confused, there's also a part of it where like it's hard to see your body changing in real time. Like you almost need so much pattern and you need so much external forces reminding you that that's not how you normally act. So even for me, maybe in early stages of perimenopause, I had 3 children, and the postpartum experience is very similar to perimenopause and menopause, with just the hot flashes and the night sweats and the low estrogen state. Every once in a while, I myself experience hot flashes and just that stickiness. It's so uncomfortable. And again, I want to say, luckily, I can kind of hover over myself and watch myself, but it's not as easy as you might think. I also, and I am kind of an open book, I use you call it the coil. We call it the Mirena IUD in the States. And I've had one of those for the last several years, which has really helped to control irregular bleeding for me, which is really common in perimenopause. It's kind of like puberty in reverse. And so I have used that for many years as a way to also control some of the uterine symptoms, bleeding, pain, cramping, discomfort, and that's kind of helped. But I still am ovulating. My levels may still be decreasing or declining. And it's funny, even I catch myself thinking, well, it's probably perimenopause. You'd think that I would know.
It's so hard to turn it around onto yourself, though. I started studying menopause as a coach or consultant just before the pandemic because I had clients who were coming to me as a personal trainer and for nutrition who were in menopause or perimenopause, and I didn't feel I could serve them properly. So I started studying, and it took me a good long while until I actually was able to see that it all applied to me as well.
As well.
It wasn't
Yeah.
denial. It was just, I wasn't looking at myself. So yeah, it's very interesting. Right. And there's always so much going on in midlife as well. So is it perimenopause? Is it life? Is it not? It's very hard to unpick.
It is.
Do you have any idea which type you might be from your amazing book, which I do have right here? It's very well thumbed and has lots of notes written in it.
Amazing.
Unlock Your Menopause Type. And what a fantastic approach, because I think being able to put bunches of symptoms into categories so that you feel you have more control perhaps over what's happening to you because you can focus on those key ones. Do you have any idea what you're in for then potentially over the next few years?
I don't. I don't know. And this is sort of fun because I will say very commonly, if I had a crystal ball for all of my patients who ask, how long will this last? Or, well, I have the same symptoms as my mom, or what will happen when I go off HRT? We kind of don't know. So the best thing that you can do is to, one, prepare by thinking about just what we were talking about leading into this, which is like, how are my mood changing? How are my periods changing? How is my sleep changing? How frequent are those hot flashes at night? And journaling and tracking, because that is gold. That really helps you when you are sort of being more subjective towards yourself. Look back and be really objective and say, oh yeah, every month I try to quit my job before my period, every single month. And so that is kind of one way you can start to be able to kind of have the best thing close to a crystal ball, which is your symptom tracking. And so I don't know which type I might be, but I came up with the types after treating women for over a decade and really starting to see that when you have this type, as you mentioned, which it makes me so excited, when you find out what your predominant cluster of symptoms are or aren't, if you're the silent type, you really can start to better refine, like, what should you think about your midlife and menopause journey? What things should you focus on? What are the treatment options or plans or routes? What should you discuss with your doctor? So I'm excited that you're excited.
I just love the approach. And even though you do say you might be more than one type, to be able to focus in is really beneficial. Would you like to explain why you decided to cluster them together and how important it is to know and understand your type?
Yeah, I would love to. I'll briefly go through each of the 6 types and then a little bit more on why it's once you kind of know those types. So the first type is a premature menopause type. And this is if you happen to have menopause before age 45. And premature menopause, a subset of that, is menopause before age 40. And this type is particularly important because this is where HRT should definitely be used. Versus natural menopause or a later menopause, where it certainly is a great option and a conversation, it really is like having low thyroid. For someone who has a thyroid disorder, we want to give you a hormone back because we know you're going to feel better. And with that premature menopause, we want to replace your HRT because without it, you have long-term health consequences. And it's nice to also form support groups with women who are going through earlier menopause because it's just so different from someone who may be a decade and a half older going through natural menopause. Next is the sudden menopause type, often from surgery, and you suddenly go into menopause. Those ovaries come out, and you're in menopause when you roll into the operating room. And we see that a lot with gynecologic cancers or women who are at high risk for cancer, like Angelina Jolie, BRCA1 or BRCA2 mutation. And so you have your ovaries out to reduce the risk. Or you may have endometriosis or some other complications requiring surgery. Some medications can stop your menopause in its tracks, like chemotherapy or Lupron. And this is really important because these subset of women are often undergoing either surgery or chemotherapy at the time of menopause. And so that makes it also very different. This is the group that probably has more contraindications to using hormone replacement therapy, but they still have a lot of options. And it really depends on their medical history. And we really want those patients to heal and feel well because they're going through sort of a shock to their system. without taking too much time, what's left? Full throttle menopause is really characterized by that, symptoms from head to toe, hair thinning, depression, anxiety, hot flashes, low libido, weight gain, and just feeling like your symptoms are just from head to toe, and often stemming from natural menopause. And so I talk about all the different options that you can treat it. And actually, because the benefits of hormone therapy outweigh the risks when started early after menopause for women without contraindications, a low dose of estrogen can honestly make the full throttle go away in like a hot second. Next is the mind and mood type of menopause. And because I see so many women whose predominant symptoms are depression, anxiety, brain fog, they feel as though they're going crazy. They may have gotten neurocognitive testing done, seen a therapist, and feel nowhere. And these women just don't think about how menopause is impacting their mood. The lingering is exactly what it sounds like, seemingly never ending. All of a sudden you look at your watch and spend 7 years. You've been having these lingering symptoms, never so bad like the full throttle that you are like, please help me. But it's just been so long. And I talk about how self-care is really important here because you may have been putting a lot of people before you finally look down and realize it was 7 years of hot flashes. And then silent is when you seemingly have no symptoms, but it's so important to recognize because your bones change, your heart changes, your brain changes, the pelvic floor changes, and you may miss routine screening tests because you feel so good on the outside. But the silent is also really, really important because we don't talk about the intersection of menopause and chronic diseases, but this is still totally evident in the silent menopause type. So that was a loaded response, but that's a brief overview and maybe a little bit into the window of why identifying your type can be so helpful when you're just navigating this wild, wild west of mess called the internet.
And the internet is a mess. It can tell you whatever you want to hear as much as whatever you don't want to hear, depending which route you go down. One of the questions that I certainly encounter the most is all about HRT. And having watched you with Oprah and Drew Barrymore and Maria Shriver, it seems that everybody is confused the world over as to when it should be administered. So taking out for now premature menopause type and surgical menopause, when is the ideal time to take it? Because over here, it's encouraged earlier rather than later. Start early, start early. I've heard women say to me, but it's nearly my 50th birthday. Have I missed my window? Equally, 60th birthday. Have I missed my window? But then Drew Barrymore was saying she's being encouraged to wait until she actually reaches menopause. What is your answer to all of that?
What is this craziness? So great question. What we know, separating out menopause from menopause by the textbook, not everyone follows, most people don't follow the textbook, is 12 months of no period. And some people like myself, I won't know if I have a Mirena coil and don't get periods. So it can be not easy to tell. But we want you to, we actually know what we don't want. I shouldn't have said that. It's ideal to start within 10 years from your last menstrual period. So the window, I guess, this old sort of window of opportunity that I didn't really coin and I also don't really love, really explains something called the timing hypothesis, which has been studied over and over again in multiple different landmark studies, including the Women's Health Initiative, that when estrogen, particularly estrogen, which is also the hormone component that treats most of the bothersome symptoms, when that's administered within the 10-year window, it's actually an anti-inflammatory. It actually releases nitric oxide, which causes the vessels to dilate and the blood flow around your heart to be better. And that's probably the reason cardiovascular disease is decreased. So we want you to start within 10 years. And by we want you to start within 10 years, I keep saying that. It means that that's sort of the window where no one's going to nag you, I guess, about it. But I get questions all the time. Dr. Hirsch, I'm 60, I'm 62, I'm 11 years after menopause. And I always say, look, the window doesn't slam shut and your finger gets caught and, it starts bleeding. It really depends on your medical history. How healthy are you? What other medications are you on? How bad are your symptoms? We know that actually for women who are within 10 to 20 years from their last period when they start HRT, there's actually sort of a null effect in terms of cardiovascular risk. You don't necessarily get the same benefit of decreasing cardiovascular disease and improving longevity because women who take HRT live about 3.5 years longer compared to women that don't when you start within 10 years. But between 60 and 70 or between 10 to 20 years since your last period kind of has a null effect. Now, if it's been 2 decades since your last period, that's when it becomes more of a pro-inflammatory versus that anti-inflammatory. And if you already have plaque buildup by that time, which statistically you probably do just because it's been 20 years and probably now you're in your 60s to 70s, it could cause those plaque pieces to kind of break off, which can increase that risk for cardiovascular disease, i.e. via clots that kind of stop blood flow from getting through the pipes. Now, even that, the risk isn't necessarily massive. It's just that, well, the risk's a little bit higher. So much of it depends on the timing, but also how long your symptoms have been going on. And I always tell my patients what risks you're willing to accept because I don't buy into this patriarchal sort of, well, I just say no because I say no. I think that women can look at the data and decide what kind of risks they're willing to take. And then in Drew's case, we're talking about HRT or MHT, menopausal hormone therapy in perimenopause, which is also absolutely safe and effective. And it's funny because I do see a lot of doctors who'd be happily willing to prescribe a birth control pill, which is a much higher dose of estrogen, progesterone, and taken orally than transdermal menopausal hormone therapy. But the truth be told, that I just think that as a medical community, doctors aren't taught about menopause. They're not taught about HRT. And if they were at all, they have no idea how to differentiate, how to use it in perimenopause versus postmenopause. So I think they say, oh, you have to be a year after your period, only because honestly, they don't know. Now, if someone disagrees with me and they have a better explanation, but I've asked around and I don't think there really is one, I think it's still a little bit of misinformation. Now, with all that being said, and I know that's a lot of information, I think that to me, as someone who looks at this data and watches my patients all the time, I really do think that the closer you are to your last period, or even if you are in perimenopause and using postmenopausal estradiol and progesterone that are FDA approved, I really think it is a nice anti-inflammatory and that these benefits clinically in terms of improvements in quality of life and living a little bit longer and reductions in cardiovascular disease are absolutely shown through. And it's a reason that women seem to starve off chronic diseases more than women who don't take HRT. But now I'll leave you with this. In the United States, I think the last estimates are only that 5 to 7% of women take HRT.
So it's not an essential. And certainly given that you're so young and not necessarily yet in perimenopause, but might be, what are you doing to prepare so that you can have a smoother ride?
Great question. Well, just like any busy human, mom, entrepreneur, I do my very best. And some days it's really great, and some weeks it's really great. And I certainly can fall off the bandwagon myself. One of the things that I do is I try to get up in the morning and do 20 minutes of exercise. And I meditate beforehand and I journal and I try to ride my bike or my treadmill for about 20 minutes. I found that more than 20 minutes of exercise takes up too much of my energy, but 20 minutes is enough for me to get moving, get my heart rate up, but not enough to completely fatigue me. And while I had previous lives of running races and marathons, for where I am in my life right now, my 20 minutes a day is all I can do. And some days it's, 4 days a week. Sometimes it's 5 days a week. Sometimes it's 3 days a week, but I really try to do it whether I want to or not. And I really try to do it for my mental health more than anything else. And just because I know it helps my body stay healthy. As you know, I have an IUD, so I try to track symptoms in the Balance app, and I really like that, but there's many out there, whether it's irritability or those hot flashes, I try to track that in there. And then I also take magnesium oxide at bedtime. You can take magnesium citrate if you have more constipation, but I found that went the other way. So I use magnesium oxide at bedtime. I take vitamin D 1000 IUs at bedtime. Those are sort of my vitamins that I take. And, at my first warning sign that my symptoms are getting worse or hot flashes are persistent or whatever symptom it might be, I will probably use a transdermal estradiol to help ward off menopausal symptoms. And again, I have that Mirena in or the coil, and that's the progesterone that's protecting my uterus in or when I add an estrogen. And I probably will. The question is, well, is HRT really for primary prevention? And the answer is no. And the textbook is no. At the Menopause Society meetings, it's no. But I look at this data all the time and I watch my patients, feel so much better and stay healthy. So I will probably use some transdermal estradiol with my Mirena coil as I start to see those symptoms become more bothersome, or I hit late 40s, early 50s, whichever happens first.
I love your approach as well as having your types. You suggest to women they hone in on their 3 most bothersome symptoms to make them feel better as fast as possible. Is there an overall top 3 that you see in your patients?
Oh my goodness. I hear a lot of, I just don't recognize myself when I look in the mirror. And that's not on the list in my book per se, but it really kind of surmises how patients come to me sometimes feeling of like, I've lost sight so far of who I was or what I looked like or who I even felt inside. Now that could be simply because by the time people are coming to me, that's sort of selection bias. They might be in such a way that they feel like that. So, that's also what patients tell me. And I'm not always necessarily the first line being a consultant. But things that really bother women a lot are weight. That's definitely something that's so bothersome because we are trying to stay healthy and starve off cardiovascular disease. And we want to maintain our physique and look like ourselves when we look in the mirror. So weight is almost always on the list. Brain fog is on the list. And it's funny because sometimes depending on where you practice, there's geographical differences. So when I was on the East Coast in Boston, which is a very sort of medical community and scientific community, I heard brain fog bother women so much. But sometimes in other parts of the country, it's not so much brain fog. So I think it's really interesting to see if there's geographical variations. Certainly, I also hear hot flashes and sleep. So particularly hot flashes that affect sleep. So sleep being disrupted is such a big one because a lot of women are kind of intuitive to know, like, I bet if I fix the sleep, I wouldn't be so moody and I'd have energy to work out and then some energy for sex and then make better food choices. And so sleep tends to be a big one too. So not feeling like myself, weight gain, sluggishness, brain fog, sleep disturbances, I hear those every single day.
And is hormone replacement therapy or hormone therapy or menopause hormone therapy, is that enough on its own?
Oh my gosh, great question. Even I use HRT, and MHT and HT and all of these words interchangeably. So does estrogen and then a progesterone, if you have a uterus, help? I'm so biased. A lot of times, yes. A lot of times, yes. It doesn't mean that if you can't take HRT, you're doomed. It doesn't mean that I believe that's the only right answer. It truly does not mean that. There are lots of different ways, and I wrote about so many in my book. But I think the reason I talk about HRT a lot is because I'm still trying to break down those myths and those barriers for women to trial HRT. And what I tell my patients a lot, which goes right along with this question is, well, if we try for 6 to 8 weeks, we'll know. You will see and you'll come back and say, oh my gosh, what a huge difference in my quality of life, in my sleep, in my thinking patterns. And so I actually like to propose to my patients who are either on the fence or still worried, which is normal. Let's not say we're putting you on HRT. Let's just do a trial and just compare it to how you feel, compare and contrast, right? For about 6 weeks and see. And so what I think is really interesting is that the answer to the question is pretty individualized. Depends what else you're doing in your lifestyle, your sleep hygiene and all of that, and your diet and everything. But when you try it, you can really start to see if there's a difference. And that's how you'll know internally if it's going to work for you.
And overall, obviously, diet does play a huge role. Looking after what you eat has a huge impact on your brain, heart, skin, everything. So health in general, as well as movement and yes, sleep hygiene, absolutely as well. All of this hopefully leading to great health, midlife and beyond. What does good health mean and look like to you?
Yeah, what a great question. It's different for everyone. When I see patients in my clinic, I actually ask them, I'll say, in 3 months, if you're the best version of you, what are you doing? And they tell me all different things. I'm getting up and I'm writing my book. I'm getting up and I'm walking the dog. I'm meeting my friends at the gym. I'm wanting to go out for dinner again. I feel vibrant. I love my job again. And so good health means different things to so many people. It really is an individualized thing. But what I think if to not sort of like gloss over the question and kind of, I think what makes women thrive in life is big things like having a purpose and making an impact or making a difference or feeling fulfilled in the life that you've led. And when you feel crummy, when you can't sleep, when you're sweaty all the time, when you don't want to wear your clothes or see your friends, you're never going to feel like you're really thriving or you have a great PIL, which is purpose in life sort of metric. And so those are the things that you want to hit. You want to be purposeful with your actions, with your choices, and not making them out of just not feeling well and kind of making them out of necessity. You really want to have sort of more control over that life. And I think a lot of us as women, we also like that feeling, not too much, but enough that you really feel as though you're living a fulfilling life, that you're happy with your choices, that you're making an impact in whatever area you're excited about. I've had patients who volunteer at animal shelters, volunteer at women's clinics, volunteer at homeless, do things for Ukraine, are big in their job, are huge matriarchs of their families, have grandchildren that they want to babysit, they want to travel, go on cruises, take up a second career as photography, like all of these things. When women are mistreated or sort of pushed to the side at menopause and they have symptoms, they don't thrive. And that's why I never said I was going to go to medical school and be a menopause doctor, but that's really the reason now that I am a menopause doctor.
I love that. Your purpose serves everybody else's purpose. And you're so right. Having purpose is what gets us out of bed in the mornings. Thank you.
Yeah.
Heather, where can people find your book?
You can get it anywhere books are sold. So Target, Barnes & Noble, Amazon, Walmart, and I'm sure there's more retailers as well. And the book hits shelves June 6th, 2023.
And where can people find you if they want to get in touch or learn more about what?
Absolutely. The best place to find me is my website, which is heatherhirschmd.com, or I'm at heatherhirschmd across all social media platforms.
Wonderful. Thank you so much, Heather.
You're welcome. Thank you so much for having me on. I'm so excited. Thank you so much.
Thank you so much for your time. Take care. Bye.
Bye.
I will put Dr. Heather's details in the show notes as usual. At time of release, June the 5th, 2023, Unlock Your Menopause Type is out tomorrow on June the 6th, 2023. Please leave a review wherever you get your podcasts to help others discover us and hopefully find some reassurance that they are not alone. Drop me a line, hattie@realmenopausetalk.com, and let me know your thoughts. Thank you for listening. I look forward to seeing you in the next episode.